So here's the thing, the human body will respond like a Swiss watch if you know how to wind it. And so what I do developing these kind of mathematical models and leveraging physiology is simply figuring out the innate mechanisms of the athlete. For example, every athlete, or indeed any patient in rehab, responds to training, exercise training, in their own way. And you can calculate that with surprising fidelity, and that's important.
Hello, everyone, and thank you for listening to another episode of our podcast. Today, I'm speaking with Dr. Philip Skiba. Philip is a distinguished physician and exercise physiologist, renowned for his expertise in elite athletic performance. He currently serves as Associate Professor and Fellowship Director of Primary Care Sports Medicine at Thomas Jefferson University in Philadelphia. That's where he's calling in from today. Philip, thank you for chatting with me today.
Hey, thanks for having me. It's a pleasure to be here.
Excellent. So would love to get a bit deeper into your background. Could you tell us a bit more about yourself?
Yeah, I wear a lot of different hats. So like you mentioned, I'm an associate professor here at Thomas Jefferson in Philadelphia. And basically what I do here is we do all of the sports medicine. When you think about sports medicine and you think about injuries and things like that, we handle that kind of thing. But we handle a lot of the stuff that isn't, strictly speaking, injury related. So primary care sports medicine is about, geez, this guy's a marathon runner. Do we need to adjust the kind of blood pressure medicine he takes for him to have his best performance? Or, this particular athlete is a strength athlete that maybe they're not getting enough protein in their diet. Okay, well, what can we do to help work on that? So we cast a much bigger net than the typical when people think about sports medicine and a hurt knee. We do a lot more in addition to that. Now, as you mentioned, I'm a physiologist as well, and a lot of my work is with both amateur and elite athletes, optimizing performance and kind of tuning their physiology. So we'll do laboratory testing on them and things like that and try to optimize performance. But then kind of the third thing I do is the actual work of coaching and consulting for elite athletes and amateur athletes who really need the kind of day-to-day input and hand-holding to develop their program properly, to make sure that they peak for the right event, and that kind of thing. And that's really a lot of fun. That's how I end up working for people like Nike or working for different kind of world champion athletes who just need to get a little bit faster.
So very diverse fields, very specialized in many ways. How did you get into this? Maybe like peeling back the onion, how did you decide, first of all, to become a physician?
You know what? It was very much an accident. I grew up in a family of of teachers, engineers, and then in healthcare. My dad's a dentist, and when I got out of college, I thought I was going to be a dentist. And I did about 4 or 5 months in dental school. I got through my first semester, and I said, "This is not for me." And so I bailed out of there. But the program I was in, I was getting both my dental degree and a PhD. So I did some of my research work like I was supposed to, and kind of figured out what my next move was. About that time, I was diagnosed with testicular cancer. And so I got an up close and personal look at the healthcare system.
No kidding.
At age 23. And I had great doctors and I had a couple terrible doctors. And I was like, I can do this better than these knuckleheads. So next thing you know, I'm applying to medical school. And again, there's a lot of serendipity that goes into it. For me, part of the challenge was I had already been through professional school until I was going to dental school. And then I was working on a PhD that I was going to leave to do medicine. And a lot of medical schools were interviewing me and saying, why should we take you? Like, how have you shown that you can stick to something? And I didn't have a great answer for that question. But I got lucky when I interviewed in Missouri, and Dr. Max Gutenson, who at the time, I think he was in his late 80s, he was the emeritus dean of the school, says, he adjusts his hearing aids. He had these giant kind of Master Yoda ears. And he says, so Mr. Skiba, what made you want to be a doctor in the first place? And it was use of first place, right, that made me think for a second. My granddad in the Second World War was surgical nurse to Charlie Mayo of the Mayo Clinic.
Wow.
And so he would tell me these extraordinary stories. And I said, actually, and so I mentioned Charlie Mayo and what I had learned, my grandfather had taught me about it. And his eyes just light up. He's living in Missouri for 50 years, but as a boy, he came from Minnesota. Mm-hmm. And he said, Charlie Mayo, he's like, I knew Chuck Mayo. He was a hell of a guy. Your grandfather worked for him. You're working for me. You're coming to Missouri. And
wow.
20 minutes later, I got a phone call in my hotel, and they were like, Mr. Skiba, Dr. Max is not taking no for an answer. So if you would just come back and sign the papers, that would be great. And that's how I become a doctor.
But what a great story. And yeah, like you said, the journey is never kind of a straight line. You're going to med school, you're becoming a doctor. Why do you choose to focus on sports medicine? You didn't mention anything kind of in athletics in your background. You were talking about education, dentistry.
I was I had been a lifeguard. I grew up on the beach in New Jersey at my grandparents' house every summer. So surfing and fishing and lifeguarding and all that kind of stuff. And so I was always into that kind of thing. And I played some volleyball, and I played for my freshman year. I walked onto the college team. But in fact, I'm really not a tremendous sports fan. But when I had my cancer scare, I made a list, bucket list. And, when it turned out that I was going to be fine, I'm sitting there talking to my dad. I'm like, I made this list of all the things I wanted to do before I died. And my father said, Phil, you just learned that life is not a dress rehearsal. You should hang on to that list. And so I started checking things off. And one of the things was a triathlon. I wanted to do a triathlon. So a couple of guys in my medical school class, one was a former pro cyclist, or two were former pro cyclists, and one was a pro triathlete. And so these guys came along and said, hey, we can help you train. And they were killing me because I'm just not an athlete. And so at least not that kind of athlete. And so I talked to my physiology professor and said, there's got to be something here I can use to get better at this. And he's like, well, actually, there's mathematical models that help govern how you the optimal way to train somebody. And I'm good at math. So that my eyes light up. And so I started digging into that world and realizing that athletes' bodies are incredible places to do experiments because of the level of physiology they have. Like for me, I got a lot faster, but I was still very slow by elite athlete standards. But when I applied what I learned to good athletes, like the fellas I was in the school with, man, they started crushing it. And so that kind of got me my start. Like, wow, maybe I should be working with athletes professionally, for a living.
Interesting how that one event, having cancer diagnosis at an early age and recovering from it set you on multiple tracks, actually, and opened up a lot of different ideas on how to pursue your vocation in life. And so maybe let's continue with the story. So you're in Missouri, you're a doctor now. What takes you to Philadelphia?
There were a lot of dog legs in there. So I first started out my career at Georgetown National Rehab Hospital thinking I would do physical medicine and rehab. And it just wasn't enough hands-on kind of musculoskeletal medicine for me. So after a year, I left there to actually go do a family medicine residency. Because I rotated there as a student, they promised me if I came as a resident, I could stay and get into the fellowship without having to go through the match. So that seemed like a good deal to me. So I ended up in New Jersey to finish up my training. And at the same time, I'm working on the side with athletes of better and better caliber. In 2008, Joanna Zeiger, who was an Olympian for triathlon in the U.S. back in 2000 in Sydney, calls me up out of the blue and says, hey, I'm getting ready to retire. I'm 38 years old. I got fourth at the Olympics, which was like worst place. Like you just dropped the medal stand. And she's like, I want something to show for my effort when I retire. And I hear you're the guy that might be able to do it. And which is a little bit scary. But Joanna had a PhD in genetics. And so she understands science. So I tell her what I do and she's all in. And that year she went on to win 6 of the 7 races she entered and set the world record and won the world championships at the half Ironman distance. Oh. And now my career is made because the British call me and say, hey, we've got the London Games coming and we need to punch above our weight. How would you like to help us? So I end up moving over to England. And so I became a program director for sports medicine at the University of Exeter. And on the side, my night job, that was my day job. My night job was helping train their athletes and develop the kind of software systems and equations and math that it would take for them to really perform at their best. And we ended up getting a gold and bronze in triathlon, and that was pretty cool.
Really, I love how the journey has really shaped your experience as it continued to evolve. And so maybe let's get into the heart of kind of what you do in the world of sports medicine and physiology. It sounds like you've uncovered kind of some secret sauce where science and athletics and maybe technology come together to deliver outcomes. Talk to me about that nexus, that meeting point of the three.
So here's the thing. The human body will respond like a Swiss watch if you know how to wind it. And so what I do developing these kind of mathematical models and leveraging physiology is simply figuring out the innate mechanisms of the athlete. For example, every athlete, or indeed any patient in rehab, responds to training, exercise training, in their own way. And you can calculate that with surprising fidelity. And that's important. For example, if you take 2 very elite athletes, for example, Joanna, who was an Olympian, and let's say one of her contemporaries, Kat Morrison, who was a 4-time duathlon world champion, if I test them in the laboratory, they have very similar numbers. But when I analyze the way their bodies perform, what I find is something interesting. Joanna requires a long, slow build in training and maybe a 2-week taper to reduce the stress and for her physiology to peak in time to really be well rested to race. Cat needed like 5 days. Now, if I had trained them on a squad exactly the same, one would overperform and one would underperform, right? And so what I try to do is bring those tools to bear for athletes, say recovering from an injury, or just a person, someone off the street who's had a surgery and we need to see how they recover. And so what we do is we measure the amount of, say, rehab that they're doing, and we measure how their performance, as judged by, say, a therapist, is improving over time. And we run the same equations. And we say, yeah, this person, you can push them harder. Or this person, no, you should probably not beat them up as hard as you do every day. And then you get much, much better outcomes.
It's interesting, I think of this more broadly as the direction that healthcare is taking more towards personalized medicine.
Yes.
A lot of that, and it sounds like that's what you're doing, a lot of that has to do with really measuring the right things and knowing kind of to what outcomes you're measured against, which I think has been an inherent challenge. If you think about how we've tried to move towards, more of outcomes-based analysis and more towards personalized medicine, we've adopted a lot of tools, electronic medical records, we have a lot more data. It's not always clear that we're measuring the right things. Maybe in your experience, in your domain, have you been able to hone in on really the right factors and identify them, and also develop maybe the right technologies to measure these things to know that will drive the right plan that's personalized for this individual?
Right. And this is the difference between working with a huge population and working with individual people. It's that you need to identify what you're trying to improve. For example, an athlete may be lifting weights to work on their strength. They may be running to work on their, on their endurance. But if they're a triathlete, they're also swimming and they're cycling. Well, you can't measure performance in cycling and think their body responds on the same schedule as it does when you run them. It doesn't. And in fact, the differences can be substantial between sports. And the problem I think we have in medicine is that no one's learned that yet, is that you need to measure the thing you really want to know about. Pick the right variable. If it's blood pressure, you actually got to measure blood pressure, and you've got to do it regularly, because little points twice a year when they happen to come into your office is not going to cut it. And people are figuring that kind of thing out. I think that the challenge is that people don't want to do the work. Like, it's not easy. It's easier just to throw pills at someone and get them out of the office.
Also, the incentives maybe aren't aligned. Again, you live in a different world where it's much more tailored to the individual, right? But at the end of the day, what we measure is often driven by what incentives exist. In a fee-for-service world, I can appreciate why we're not always measuring the right thing, even if we have an idea of it, just because the reimbursement might not support that. It might not support that test, or it might give us an incentive to prescribe or overprescribe medication. Right. To deal with the symptom, not with the root cause.
The challenge is that so much of what we do is being driven by an insurance industry that makes its money by not giving care, right? Like, what we do is we take your money and then we don't provide anything in return, and that's how our stockholders get a return on their investment. And so you have this like perverse incentive to not really care for people, and that's unfortunate. That it's that way. And I think we need to do something about these kind of perverse incentives, because most of them are penny wise and pound foolish, right? Oh, we're not going to pay for these meds. Okay, great. So instead, the guy has a giant MI and an ICU stay for a month that costed $1 gajillion. If 5 years ago we had just put him on the slightly more expensive cholesterol medicine, maybe this wouldn't have happened in the first place. But writ large, I think our challenge is that a lot of times we don't have the best business people coming into medicine. Right? There's very quarterly thinking. How do we make our numbers this quarter? How do I get my bonus this quarter? They're not thinking 10 years down the road, the way you ought to be thinking if you're running a big organization, right?
Yeah, and that's maybe the point around, misalignment of incentives. A lot of our audience, Philip, are technologists. And so it sounds like technology plays a very important role in this transformation that you're leading in personalizing care plans and personalizing athletic development plans. And I think that's true of many other areas in healthcare. What role does technology play in your space? And maybe what advice can you give to entrepreneurs who are looking to ensure that their tool, their widget, their product actually does measure the right thing and can lead to that longer term outcome that you're aiming for?
So here's the challenge that you have in the realm of sports science, let's say. The barrier to entry is very, very low. Okay, many sports science programs were developed for us to have gym teachers, for example. And so, the challenge we have there is that since most of these programs for sports science were really meant to develop like gym teachers and things, they're not really developing scientists. So when they try to develop, they get involved with a company that wants to develop a device or an approach, the people they're consulting don't even really know what it is they're supposed to be looking at. And so what you really need to be sure of, you may have a bright idea. You may have 10 trainers or something from gyms telling you this is a great idea, but then some sports scientist is going to tell you, you know what, that's nonsense. And that doesn't really work. It doesn't work like that. And I've seen that again and again as I've worked in consulting roles with different kind of corporations that are developing products. And I got to be the jerk that tells them if they've spent a bunch of venture capital, actually, guys, this is not how the body works. So you need to have scientists, good scientists in on the ground floor when you're first thinking about your product, when you're first thinking about the development. And if you're able to do that, you have a much better chance of success, going forward.
And throughout your career, it sounds like you've had a really unique approach to working with industry. You worked with Nike, I know, on a big project. You've worked with different non-provider athletic organizations. How do you find that convergence of, the private sector and healthcare coming together to solve these problems, to maybe, to your point, to really understanding the ins and outs of the problem and then making sure they together build the best tools to measure or to address that issue?
Yeah, I mean, the difference often is that in private industry, you're working with Nike. Nike has a very large checkbook, and they have a lot of people really interested in doing it right. Like, for example, when I was working on the Breaking 2, the 2-hour marathon project, they were blowing tens of millions of dollars to try to break 2 hours in the marathon. They wanted to be sure things were done right. They were willing to spend the money it took to do the job right. The challenge you have in healthcare is everyone's trying to operate on a shoestring budget. Right. And, like the engineers in my family have a saying, right? You can have it good, you can have it cheap, or you can have it fast. Pick two. And I think our challenge in healthcare is that we're always trying to say, well, we don't have the funds for that, so we don't invest. So we don't end up improving approaches because we're just trying to figure out how do we survive in our budget until next month, next year, next quarter.
And so how can healthcare still has a different mandate, right, than the private sector? It's generally not only driven by for-profit. Certainly not the provider side is driven by care, by the Hippocratic Oath. So there's certain elements that they can adopt from the private sector, but they're nonetheless have a different ethos. How can we synthesize? How can we take kind of the best of the longer-term thinking that's maybe capital efficient of the private sector, coupled with this broader mandate to better humanity that's a not-for-profit orientation that the provider world brings forward?
Yeah, and I think you ask a very good question. I don't know that there's a straightforward answer to it. So many of us are so beholden to what payers will pay for. And so I think part of the challenge is that when we talk about disruption, what you need are people who think outside the box. One of the ways I've been very, very successful is by understanding that I am not the smartest person in the room, and I don't want to be the smartest person in the room. I want to be the guy that identifies the smart people and get them in the room with me. And that's why I've had all the success that I've had. Like, most of the really cool things that I've developed in concert with very good engineers, where I can say, guys, here's what we have to do, and, on the Breaking 2 project, we had physiologists and we had engineers and we had biomechanists and, product development specialists. And so that everyone brought their own thing to the table. Medicine tends to be very siloed. And frequently the kind of doctors that end up in big leadership positions, number one, they're not business people to begin with. They may have gotten an MBA or something, but frankly, in general, it's the exception, not the rule, that you get a really visionary business person who's involved in something in healthcare. Those guys are working for much bigger organizations with much bigger budgets. Nike's a $50 billion organization. That's why they attract the kind of people that they attract. And in general, healthcare doesn't work that way. So I think what we really need to focus on is identifying the people that help us solve these problems and then getting them in the room together.
I think that's a great call to action to both providers and technologists to find new ways to collaborate, work together to really get the smart people in the room to make sure you have the right data, the right evidence, the right scientific basis to make sure you're solving the right problem, and then collaborate together on finding the solution.
Yeah. The other challenge that you have is that you need to find visionary people and then cut them enough slack to do what they do. Mm-hmm. Like my last job with Advocate Aurora in Chicago, I was there for 12 years. I developed $35 million in new facilities to do this kind of stuff. And the reason I was able to do that was I had Dr. Tarek Harriman, who was the CMO above me, gave me, I told him what I wanted to do. I told him why it would be good from a financial standpoint. He said, great, Skiba, here's a check. The first lab cost about $100,000. And he said, make it work. Off I went, and I started that ball rolling, and that was 2014. And by the time I left this year, we had just finished opening a $30 million sports and medicine and health center. So I was lucky in that I had people above me that saw my vision and understood that it was going to take a different approach, that it was going to take some money, that it was going to take some time. It took 10 years to get where we got. But that's what we need is, again, Tarek was a long-term thinker. He saw a vision down the road. He wasn't saying, yeah, but Skiba, how are you going to see 5 more patients this week, right? He understood that there was an investment to be made in the long game. And that's what we need in healthcare, is more people interested in the long game, not how do we get 5 more patients in this week.
I love that. That's a vignette if I ever heard one. Philip, could we come back to the Nike 2-hour marathon project? That's so intriguing. And actually, I don't know, was it successful? Were you able to get runners under 2 hours?
Yeah, so it actually happened in 2 parts. So during the first effort, which we did, which was in 2017, and we did that in Monza, Italy, and we got down to 2 hours and 25 seconds. So my model showed that we should be able to go 1:59:45, and we just went a little bit short because it rained that day. And when you get wet, you can't exchange heat as well. So your temperature runs a little bit higher, so you're not going to be able to perform quite as well as you should. And so we just came in a little bit slow.
I can't believe the precision on a 2-hour basis. I mean, there's a lot of, oh, wow, that's amazing.
No one is more surprised than me that this math works. I got news for you. I'm surprised every time I make one of these predictions and it comes out within a few seconds. It's pretty cool. But anyways, so the following year, a company called Ineos, which is like a fracking company from Great Britain or something, in an effort to kind of greenwash themselves, they set they paid to try again. They basically did exactly what we did, except they did it in a different country with better weather.
And what was the outcome?
I think it was 1:59:48 or something. So it was like 3 seconds off of my prediction.
There you go. Wow. So we've come to the topic of technology kind of at a high level, but maybe in really carving this innovative pathway to get the most out of professional and amateur athletes, what technologies have you used? What are some of the technologies that are novel that you've integrated into your practice?
So wearables are the biggest thing. Because it allows us to monitor in real time what the athlete does. Like, well, I was training all these African athletes. They were in Kenya and Ethiopia and Eritrea and Spain. They were all over the place. And so what we did for these guys was put Garmin smartwatches on them. And every time they ran, every time they worked out, it recorded it, and they would go to their cell phone and upload the data to me. And then on this side of the world, I'm able to look at that data, analyze what they're doing, and then we make some calls about what the right thing to do is. And so one of the things I've been developing is a way to just simply apply this technology to patient populations. And in fact, when I was in Chicago, we were working on a project exactly like that. But again, we had people that were, say, oh, well, do we really want to invest in buying these devices, these accelerometers or these Garmins or whatever smartwatch we wanted to use to measure this? Like, why should we spend that money? And it's like, and again, this is quarterly thinking, not, if we get all these people doing exercise and we can measure it and we can incentivize them, then they don't have MIs, then we save a lot of money by not putting them in an intensive care unit. But that's not on their sheet. That's not what they're concerned about. And so that was really kind of an uphill struggle.
In our space, I run an ultrasound company, and we also see that, technology is miniaturizing ultrasound, the ability to collect these sound waves. And, we're seeing the advent of wearables, some of which are kind of different form factors like patches that can offer some continuous monitoring, but still really haven't seen a breakthrough of that in terms of monitoring a disease state. And some of that is maybe that breakthrough still have to occur not on the acquisition side of the device, but also on the AI and on the data, because I think the FDA is, worried that, data that you're collecting directly by the patient could be interpreted or misinterpreted, right? And you need AI to provide much more of a binary decision or binary outcome that analyzes what it all means. Where do you see this wearable space continuing to evolve into kind of straight up healthcare and medicine? Are there other use cases, like you brought up AMI? Are there other use cases you see that are on the cusp?
The challenge you have right now is everyone wants to invest in AI, and it's really not very successful. All right. And I encourage people who really want to jump on the AI bandwagon to sit down with ChatGPT someday and ask it some questions that you know the answer to. Things that have, robust, good scientific answers that we know with certainty. It gets it wrong a lot. And part of that is that no one really understands how they work, and no one really understands how to train them properly. And that's really the challenge that we have, that you can have these things in a safety sensitive thing like flying an airplane or doing healthcare, and it making a catastrophic mistake. What my experience has been that you get much, much better results. And I say this as a guy that was consulting for a company that blew millions and millions of dollars trying to find an AI solution to training athletes better and failing, is that much simpler equations will put you in the right direction. For the simplest example of that is, how well an athlete performs is equal to their fitness minus their fatigue. And that's a very simple equation, and it makes sense. And that's a simple expression of a slightly longer actual mathematical equation with variables in it. But with just 4 or 5 variables, you can get impressive fidelity, where I can tell you within a couple of seconds where an athlete should perform in a marathon. And that's the thing, is that there is plenty of technology and plenty of math and plenty of research that we can leverage, but we're too busy glomming millions upon billions of dollars into this new hotness. It's like, talk to an engineer and say, how can we solve this problem, simply, versus burning $1 trillion in venture capital. I just don't think the right people are at the table to have these discussions.
So I hear another call to action there of keep it simple and keep it down to what really matters.
Yes.
And I think that's something that's good advice to technologists, right? Because sometimes we do get caught up in the bells and whistles of what our product does or what our technology could do.
I'll tell you a story about that from the Breaking 2 project. One of the athletes we trained, a guy named Jefferson Health, he held the half marathon world record. At that time, it was 58 minutes and change. But he had never run faster than about 2 hours and 15 minutes for a marathon. That doesn't make any sense. Why should he lose 15 minutes or 16 minutes or 18 minutes over the following half marathon after the first half marathon? That doesn't make a lot of sense to us. So we're sitting at dinner and I say, Zersne, what do you, when you run, what do you drink? And he says, I don't understand the question. So when you're running, what's in your bottle? Is it Gatorade? Is it water? What's in your bottle? And he says, Doctor, when I am running, I am not drinking, I am running. And I said, Zersne, are you telling me that you're running a whole marathon without taking a sip of water? He said, yes, I'm from Africa. And it was kind of mind-boggling. So what did we do for Zersne? We taught him how to drink, basically Gatorade or whatever product we wanted to use for the event, and we knocked like 8 minutes off his marathon time, right? The problem wasn't, he didn't need a new shoe. He didn't need a new training program. He needed someone to tell him to drink Gatorade. So you could have thrown billions of dollars at him, right? We spent tens of millions of dollars developing the Vaporfly shoe. That's not what he really needed. What he really needed was someone to tell him how to drink.
Sometimes the simplest solution is right in front of you.
That's where we are.
Absolutely. Wow. This is fascinating. I really appreciate how you've opened up the world of elite athletics tests. And I think so many takeaways here that apply to the broader realm of healthcare, on prevention, on solving the right problem, on creating the right coalition, having the right data, and really addressing what's directly in front of you and making sure you don't lose sight of that. As we start to bring our podcast today to close, if our audience want to learn more about you and what you're doing, where can they follow you? Do you have a LinkedIn handle, or where's the best way to learn?
I'm certainly on LinkedIn, but I don't spend a lot of time there. You can find me on my website. It's physfarm.com. You can also find me on Twitter, or now it's called X. I'm not on there very frequently. I'm actually more on the alternative app, which is called Blue Sky. So lots of places you can track me down. I'm not hard to find.
Absolutely. Philip, I am definitely going to keep tabs on you. I want to keep learning about this journey and keep thinking about how technology can play. We have a big stake in this domain, my company in particular, and I think many of the entrepreneurs here can learn a lot from all the wisdom that you've imparted on us. So thank you very much for being with us today.
Yeah, thanks for having me. It was a pleasure.
And for our audience, thank you for joining us for another episode of our podcast. That's a wrap.